Hi everyone, welcome to the Med Student Notes. Today we're going to talk about cystic fibrosis. I quite like how this whole picture turned out, but before we discuss this, I want to go to the very beginning of the story. At the beginning of the story, we have a cell, we have a nucleus. In the nucleus, we have DNA. DNA gets transcribed to RNA, RNA gets translated into protein, right? So, there is a gene on chromosome 7 called F508 that helps code the chloride channel in our body. Now, the common thing that leads to cystic fibrosis is a deletion of F508. So now, when this chloride channel is eventually formed, there's going to be a defect in it. The defect most commonly tends to be an issue with post-translational modification. Now, this protein has formed, right? Our chloride channel has formed as a protein. So what has to happen is this has to fold so that it can get inserted like an entry port so that the chloride can travel in or out of the cell. So when the protein doesn't fold properly, this channel is not going to get inserted here properly, or not enough channels will get inserted properly, or there can just be an absence. Now, in this case, we don't have chloride transport happening the way we want. And this autosomal recessive condition is caused because of a deletion in F508 gene. Now, let's go into the happenings that manifest because of this. In a normal person, the CFTR channel brings chloride into the epithelium, into the cell from the sweat. This happens in the sweat ducts, right? Now, when the chloride is brought into the cell, sodium is attracted, sodium is positive, chloride is negative. Sodium is going to be attracted to the negative charge, or you can also say that to maintain electronic balance, electrochemical balance, sodium is going to also come into the cell. So in the sweat, there's going to be a balanced amount of electrolytes. However, when there's a defect in CFTR, in cystic fibrosis, the chloride is not brought into the cell from the sweat, so the sodium also stays back in the sweat. So we have a high amount of sodium and chloride in the sweat in case of cystic fibrosis, which will manifest as very salty sweat, right? Now, the same CFTR functions differently in the respiratory and GI mucosa. It has a different function. In normal people without cystic fibrosis, the CFTR channel is supposed to send out chloride into the respiratory mucosa that lines the lumen. So we have the respiratory lumen, right? I think this is the trachea or one of the lumen in the respiratory channel. So there's going to be mucosa here lining this. Even in the GI tract, there's going to be mucosa lining this. So what's happening here is chloride is sent out by the CFTR, which stays in this mucosa. So because chloride is brought out, sodium and water will also stay in the mucosa. Sodium will stay in that place because chloride is there, and water will stay because sodium is there. Even when we're discussing kidney, when we reabsorb sodium, we reabsorb water as well, right? Similarly, water in here is going to stay in the respiratory mucosa that coats the lumen when there's a functional CFTR. But in case of cystic fibrosis, the chloride is not going to be sent out like it's supposed to. So what happens is sodium and water also come into the cell. Now, the water and sodium that are supposed to be in the mucosa to make it moist and to make the flow of air very smooth, this is not going to happen because the water is going to go inside. So the mucosa that's supposed to be smooth and moist becomes very thick and very viscous. It forms mucus plugs. The mucus is not in a very optimal form and becomes very hardened. And this leads to the clinical features that we see in cystic fibrosis. So because this mucus plugging happens and you're blocking all the lumens, you will see airflow obstruction. You will see cough and sputum, wheezing, dyspnea, bronchiectasis. You can see hemoptysis because of the pressure buildup because of the obstruction. This will cause little vessels, the bronchial vessels, to break, causing hemoptysis. You can see pneumothorax. And then the extrapulmonary manifestations would be chronic sinusitis. And an important one is pancreatic insufficiency, because in the same way, the pancreatic ducts are going to be all blocked up. So when you're not secreting what should be secreted from the pancreas, you're going to not break down your food properly, which will lead to steatorrhea. You're not breaking your fat down properly. So you'll see foul smelling, bulky stools because it's not being absorbed. Fat soluble vitamins won't be absorbed. So you'd see the deficiency of fat soluble vitamins like A, D, E, K. You'll see dry skin. You will see an issue with the bones, an issue with bleeding. You can also see meconium ileus in babies, where in the same way, there's an obstruction and the passage of meconium won't happen properly because of these hardened secretions that block the passageway. You can see distal intestinal obstruction syndrome similarly. And there's something called bilateral absence of vas deferens in males with cystic fibrosis. So they're typically infertile. So these kids will be underweight, they'll have digital clubbing, they'll have inspiratory crackles on physical exam, and you can diagnose this through skin sweat testing. The gold standard test would be a standardized quantitative pilocarpine ionophoresis. Pilocarpine is a cholinergic, it would stimulate sweat, so you can just assess the salt levels in it. You can do genetic tests to check for issues with the cystic fibrosis channels. You can do a transepithelial nasal voltage test or intestinal current measurement so in the lumen at the mucosa and inside the cell, this is the epithelium, right? So the transepithelial voltage will be abnormal in cystic fibrosis because we have discussed that the ions will be misplaced, right? They're not going to be in the places that they're going to be in. So you can do that. So cystic fibrosis patients tend to be prone to respiratory infections recurrently. So you'd want to do sputum cultures to test for Staph aureus, Haemophilus influenza, Pseudomonas aeruginosa, Burkholderia, Strentomonas maltophilia, this is not a bacteria that I've come across often. And then fecal elastase will be less. This shows that pancreatic function is not optimal. This is not done very commonly because pancreatic insufficiency you can very obviously see in clinical features. You'll see the steatorrhea and the manifestations of fat soluble vitamin deficiency. You can do a chest x-ray, high resolution CT, pulmonary function test to assess where the lung is at. Typically you would see an obstructive picture because of the blockage of the airways, because of all the mucosal plugging. And that was about the clinical features, diagnostics, and pathophysiology of cystic fibrosis. If this was helpful for you guys, I would love to go on to do another video talking about the management and treatment of cystic fibrosis. So do let me know in the comments how you found this and if you'd like to see another video. In case I went really quickly explaining cystic fibrosis, please do excuse me. You can always change the speed of the video. Also, if that has been an issue, please do let me know in the comments. And do like, share, and subscribe if you found this helpful. Thank you for watching.